This is my first presentation in 5 years following trauma myself, so it's a real pleasure to be here. So the two questions for the audience, the first one is, who is the boy that kicked the hornet's nest? And secondly, if anyone has an answer for my therapist as to why I keep kicking the hornet's nest, that would be really helpful, because I can't work it out. So we're going to talk a little bit about the neurobiology. I can only really tease you about neurobiology, and I'm glad I've decided to tease because there's actually a neuroscientist on the podium after me, and they'll give you the real information. Want to talk about the evidence base, but actually beyond that, where it doesn't actually reach. And then try and talk a little bit about approaches for post-traumatic reactions. I'm a psychotherapist, so of course it's psychological, but I'm also a psychiatrist and a doctor, so of course it's physical. It's always both. That dualist view that we separate the body and the mind has been persisting since Descartes in the 17th century. Time to move on. Okay? Most of you in the audience, I think, will get this. There's a few people who raised their hands not to knowing Zebedee, so you might not, but we do need to know it, and there's a number of reasons for that. We need to understand why people have certain reactions. I've had patients come to me and said, I've read on the internet that my brain is damaged. Is there any way to reverse that? We need to know the biology to be able to answer that question. Okay? We need to know the implications of what we do and why therapies actually work. We need to be able to psychoeducate at the right time in the right way for people to understand what they're experiencing. Not just simple reactions, but more complex reactions. And not just because we're afraid to do the work with the patient, but because giving the information allows us to do the work with the patient, with the client. And also then for credibility. DSM was created so that psychiatrists and psychologists had some credibility in the eyes of medicine. It wasn't created for science. Read the write-up. Spitzer felt it was the only way for us to be seen as other doctors were seen. Yeah? And they therefore produced DSM out of very, very unruly committees, not out of research. I'm kicking that hornet's nest already. I said, it's the problem of coming up with a good title and then trying to justify it. So there's a number of biological findings, and I really, again, can only tease you with those. Let me pick out one or two. The endogenous opioid system, many people in the audience will know or have heard that when someone self-harms through cutting, they get the release of endogenous opioids and cannabinoids, and it can relieve tension. That's okay for some people we see, but we need to know more, because actually, for people who are deep self-cutters, they're trying to overcome an overload of endogenous opioids. And actually, if you give them naltrexone, which is an opiate antagonist, they'll have the same response as they get from deep self-cutting. So actually, our response to them needs to be different. And we need to know that that is different. The immune response to trauma. There's a consultant orthopedic surgeon who had to run away from Aberdeen to Australia because he became a biochemist. And in his thesis, he studied the immune response to orthopedic trauma and found that those people who were turn attendees at fracture clinics and their fractures didn't heal were the people with PTSD. They had changes in soluble interleukin-6 receptors, so their immune response was all over the place, and they couldn't mount an immune response to recover. So is it psychological? Is it physical? Yes. Yes, it is. That won't stand on the podium, my apologies. And thank you, Clive, for getting us a table. Where is he sitting? Thank you, Clive. So neuropeptide Y I want to mention, others have mentioned resilience already. Neuropeptide Y is possibly the biological resilience factor. They looked at special forces, soldiers in America, and there's a Gaussian distribution for all of us, maybe one or two are not in that, maybe elsewhere. And then there's a Gaussian distribution, and it's a small group for the special forces. They were able to put up with things that most of us couldn't. And there will be people, as one of the other speakers was saying, who have had incredible adversity but are fine. I did the follow-up to the Pipe Alpha oil platform disaster, and there was one man stepped off that and he didn't have a day's psychological distress. I wanted to take him, I wanted to titrate him, and inject him into people. Okay? And it was remarkable. I spent hours interviewing this guy. Why is it he's so resilient? I think I knew. because by the end of it, it was very, very clear that his attunement and attachment to his family was phenomenal. It was that rescued him. Okay? I'm not sure who's going to rescue the mouse, that's what the table's for. Put this up, there's a lot of genetic studies, don't have time to go into it, but if you change the fear response in a mouse, you do it for 7 generations. Okay? So if you change the fear response in a human being, we haven't got the clinical studies yet, but what are you doing to subsequent generations? So if you want to stop this, you might actually stop it for many generations, not just this current one. If I press the right button? Aha. There's an evolution of neuroimaging studies. One of them resulted in me kicking the hornet's nest for the first time. But we started with structural, we moved on to functional studies. We then changed the regions of interest we looked at in the brain. And I'll just want to talk about those a little bit. The hippocampus was the first one. In the 1990s, there were many, many studies. Some of them confirmed previous findings, others conflicted the findings. So it gets quite complicated. I'll not go into it too much. But it was of interest because it is declarative memory, i.e. the memory that you can speak about events, about occurrences, and you can relate them to other people. And just to show you where the hippocampus is, hopefully that's showing up there. Yep. So it's supposed to look like a hippopotamus rearing out of the ocean. I've never quite seen it myself, but there you go. The amygdala, the medial prefrontal cortex, other areas of interest in early studies, and later, and ones that I'm particularly interested in, the brain stem, but that's come on much later. I added the circles and the red. That's not there in your brain, just to say. I also have to say, in one of the studies, I was a control, and I was dropped as a control because my hippocampus was worse than any of the patients. It might be growing up in Northern Ireland, I'm not sure. I'm pretty sure it was, but anyway. So you'll see that it is reduced volume in the hippocampus in the right-hand side. Now, if only it was as easy as that. There's so many different findings here. But it'll be the right side hippocampus if it's an adult. It'll be the left side if it's a child. It's the left side if it's recollections about cancer treatment. So it varies. And also remember that a lot of these studies were either on single episode sexual assault or on military veterans. So how did they generalize beyond those populations? And it's a real risk to generalize in trauma populations. There's also a study by Gilbertson, who's continued to pursue this, that it may be the volume of the hippocampus is a risk factor for getting PTSD rather than the outcome of PTSD. So that has been pursued as well. We found, and it's Satvir Minus, who's the first author, we found that actually the volume of the hippocampus was related to the severity of PTSD. That might be that the hippocampus doesn't let you recover, or it might be that it will recover when you treat the PTSD. We don't have the answer for that. I think in research you just find out better questions. Okay? You never really get to the answer, no matter how many people say we do know the answer. So the amygdala, another area of interest, and it's essentially the fire alarm. Okay, it's going to kick off the fight-flight response with clinical, preclinical evidence as well that it's involved in the fear response. This is a PET scan. There's a group of people had their trauma scripts developed by Scotty Rauch in Harvard, and then they had the script read to them, and they were put in scanners, and it looked at the blood flow. So the lighter it is, the more blood flow. So when the script was read to them, so that's traumatic condition, minus neutral, which is resting, what it would be like if you weren't trying to provoke symptoms. And their limbic areas lit up like beacons. So that's the emotional part of the brain, the fear response. The secondary visual cortex lit up as well. So they were having visual intrusive memories of flashbacks. And that secondary visual cortex doesn't know whether that's new or old image. Okay, it's on the right side of the brain, so it was for the amygdala as well. The amygdala, the right side of the brain has no time sense. It doesn't know that you're experiencing it as an old memory. It thinks it's happening again now. And actually, just to go back, the secondary visual cortex only gets interested, some of the cells only get interested when adrenaline is very, very high. So it's much more likely to respond when the amygdala is kicking off. And then we've got Broca's area. Hands up anybody who's heard of Broca's area. Yay! Good, excellent. That's more than any other crowd I've ever had, actually. I feel very alone usually. Broca's area is responsible for putting emotional experience into language that we can communicate. And if you look there, it says neutral minus traumatic. So it's actually less active in the trauma stimulation. So it shuts down when we trigger people's trauma. So we talk about the unspeakable trauma. In your brain, it makes it more difficult to speak about. Does that make sense? Okay. Doing something with this every now and again. Come on, button. Aha. So this is the first instance of then kicking the hornet's nest. Well, not the first, but the first in writing. And I wrote that Broca's area was basically compromising talking therapies. I had to get assistance because the email flow to me was huge. I think it was 2,500 emails, and not a lot of them were complimentary. Okay, so be careful kicking the hornet's nest. Okay, this is just a representation. It's based on work that Bessel van der Kolk has done that lots of people I'm sure will have heard of. Well, very well known. It's representational. It's not supposed to be the neuroanatomy. But sensory stimulation comes into the brain. This is the emotional memory system of the brain. Sensory stimulation comes into the brain. It comes in as fragments. So everything you see, everything you hear, everything that you touch or move, the gustatory, the taste, and the olfactory, comes into the first filter, the thalamus, tells us whether or not to pay attention to it. Okay? This is simplified, but it's just helpful. Bless you. Wasn't sure if I'd said that. I didn't mean to. Okay? Olfactory, as I say, will go to the second filter, which is the amygdala. So it's going to tell us whether it's emotionally important. So if you think about birthday parties, everything you see, hear, touch. So you might see a friend you haven't seen in years, you smell the cake, you taste the food, you get the bumps. If you're old enough, you'll get the bumps. If you're young enough, you'll wonder what on earth they are. And if it's emotionally important, you will then pass that on. Okay? They passed on the sensory fragments. It's not yet one memory. We then pass it on to the organizational part of the brain, the hippocampus and other areas, and that then makes one memory out of it that's then stored in the prefrontal cortex. Okay? And you store the birthday memory with other birthday memories, which is why my mother's convinced my 18th birthday party was great. I was on another continent. She was at my 16th. She wasn't at my 18th, but that's her memory, her filter. That's how she's logged it. And it's so long ago, I'm not sure how she remembers it, let alone me. And at the time of trauma, as I experienced just now, sorry, there's a slide before that. So there is a slower, more elaborate system as well. But at the time of trauma, this breaks down. And sensory fragments then get passed for storage as a fragment, not as a whole memory. And then when they're triggered, including by us as therapists, they come back, the original fragment of memory, the smell or the taste or the sound, with the original emotion. That is intrusive memory, that is a flashback. And because it's happening on the right side of the brain, it feels like it's happening now for the first time. Okay? And at the same time, of course, Broca's area is shut down, so you can't put it into words. Okay, and you've usually got a damn full therapist in front of you asking you to put it into words. Okay? And I include myself in that number. This seems to be intermittent. It proves it's probably me. Okay? So then thinking about the triune brain. People heard of that? This idea that we've got a reptilian brain, a mammalian brain, and then a human brain on top of it. And just want to then go from the limbic system towards the midbrain, which houses, importantly, the periaqueductal gray, the PAG, and the superior colliculus. Jaap Panskep, who sadly died at the start of this year, did a lot of research in this area. And he's a hero to one or two of our friends. And he showed that all of these very basic emotions that we're talking about originate in this midbrain, either from the ventral tegmental or from the PAG. If you remember at least PAG, that's where most of them come from. Now we can't study shame apparently because you don't get shame in animals. Any dog owner will tell me, yes you do. Okay, and I've spoken to vets about it and they think, yes you do. So maybe there's more research to be done. Neuroception as a principle is really just tying in with a polyvagal theory, which I know is one that lots of people have known about and read about. But basically the neural circuits then distinguish situations of people that are safe, dangerous, or life-threatening and allow the responses to that. Okay? It's pro-social or defensive behaviours, and they originate in the brainstem, in the midbrain. Sorry, someone was taking a photograph, I'll go back. Okay. So we're looking then at the mesolimbic dopamine system, and I just wanted to show this diagram very, very quickly so you know where I'm talking about. So we've got from the ventral tegmental area, the mesolimbic dopamine system rises up to the prefrontal cortex. And this is a diagram that hopefully makes it understandable, because the other one I don't understand either. It's from a colleague, Frank Corrigan. This is from Frank as well, but this one I understand. So normal seeking, hopefully like now for most of you, is dopamine system. These are parallel systems rising up in that mesolimbic dopamine system. If, however, I trigger you one way or other, if you think I'm playful, you'll go into the other one and you'll be happy seeking. Oh, I want to know more. We're talking about neurobiology, so it's probably unlikely. It might be scary, and you're then going into fear, grief, rage, and it's different neurotransmitters that are leading the day. But what this does is raise the potential that when people are suffering unhappy seeking, rage, grief, shame, that there is a system running parallel to it where we can resource them into happiness so that we present the paradox. And the paradox being is that I feel safe, I feel okay, I feel comfortable, I can trust. At the same time as stepping into the memory that makes you think anything but that. You're terrified, I'll not survive, I'm going to die. And it's presenting that paradox that allows us to deconsolidate a memory, change it, get rid of the emotion, and then reconsolidate it and store it. And that's health. Okay? Okay. I think that's Michael Whitgate, who was in one of the movies a very long time ago. So, looking at other studies, just very, very quickly, we've got the studies of dread. People put into a scanner, they've got a predator attacking them, and the brain switches from the cortex to the midbrain, to the periaqueductal gray, and to the superior colliculus. They're close to the predator, and when the predator gets to them, those areas are active. And you look at the scans on the bottom left, that's when the predator's far away, and it's in the cortex. And then in the top right, it's the PAG that takes over. You're in the fear response. You're terrified, you're trapped. We've also got, I've talked about the amygdala as being an area of interest, and there's been real-time fMRI studies of neurofeedback, which are really intriguing because it showed that you could get individuals through neurofeedback to downregulate their amygdala and to increase the connections with the prefrontal functional regions and the neural networks that are needed. So that's a real hope there for actually being able to directly target the fire alarm. We want to switch that off, okay, or at least dampening it with a very wet blanket. We just need it to settle down. And there's also similar findings for people with borderline personality disorder, again reducing that amygdala overactivity. If you look at the studies on borderline personality disorder and you rule out trauma, you lose most of the brain findings. It's about trauma. Okay. I'm trying not to kick that hornet's nest. That's for another day. Looking at dissociative reactions. And again, it's just helpful to know what's going on. 3 groups of people, one who could tell the story of the trauma, they didn't have PTSD, they didn't have a post-traumatic reaction, they could just talk the autobiography of their experience. One who had intrusive memories and got very hyper-aroused, and another group who had dissociation and got very hypo-aroused. And what, whoops, I'm clearly hyper-aroused and did excessive button pressing. Where did that go? Jeff, I'm pressing the right button. And you'll see that the thalamus and the insula in dissociation become more active. And they change their activity. The insula becomes less active, and the insula is the part of the brain, part of the limbic system, that tells us about our body. So under dissociation, you lose your body. You don't know what it's doing, you don't know where it is. Okay? So the superior colliculi in reptiles, it's there to look for danger or for things that attract you. You go towards the social, you go away from the threatening. Okay? We use it for social engagement. You can see how we trip up, how we look at faces and we get fearful, or how we can find joy in the other person's face and go towards them. Okay? And the PAG in the superior colliculi, 60% of the connections are to each other. Okay, so that's social engagement and then those intense emotions. Again, very helpful to understand. And probably then allows us to understand why therapies that use eye movements or fixed eye positions are very, very useful within therapy. Oh, skip past that. So the main findings There are many. So under threat, we shift from the cortex to the midbrain, to the PAG and the SAC, sorry, the superior colliculus. Okay? There are different changes for different disorders. It's not all one. Okay? We get hippocampal atrophy, we get increased activity in the amygdala, there's deactivation in Broca's area, and we've got to remember the right hemisphere is where trauma is held for the most part, although clearly I've said for left-hand side of it's childhood trauma. Okay. That's the end of the first bit. I almost put Dr. Hull, but decided I wasn't arrogant enough for that. I was too arrogant to be that arrogant, I don't know. So then treatment. Okay. Now the first thing is, of course, do we agree in diagnosis in the first place? Are we therapists and we believe in formulation? Well, I'm a psychotherapist and I treat symptoms, and I'm a doctor, and then I treat symptoms. I'm not supposed to, I'm supposed to treat disorders, but we treat symptoms. As I say, DSM was to collect symptoms and validate why we had psychiatrists. That's why it was there. Okay? There's a number of difficulties in treating. I don't have time to go through all of these. One, and it's a hobby horse of mine, patient was discharged because they failed to engage. The therapist has got to be available for the patient to engage with them. They've got to be giving the right therapy at the right time. It's got to be the right person. It's not just about the patient. It is also about the patient. And it may be, if we haven't dealt with our own shit, our stuff, that they don't feel safe being in the room with us. Why on earth would they feel their system's not activated, or if ours are activated, if we're afraid? Now, the neglect of the complex, we don't ask. I had a patient with very severe dissociative disorder who had never been asked in 20 years of contact with psychiatric services about any dissociative symptom. Okay. When we studied NHS Tayside in patients, we find that 44% didn't have their worst trauma even written in their notes. And on average, they had 5 trauma. And their trauma happened before their psychiatric illness. So, what can we do? Well, we clearly don't need any more paddles. We need to just use them a bit better, I suppose. Or some canoes. That would be helpful. We've got a legion of psychological therapies. We have been so inventive, and there's more added all the time. My conflict of interest, I'm going to declare. The green ones I did during early training. I have either been trained in, written about, had experiential treatment, or had treatment by all those in yellow. Okay, so I have a conflict of interest. I'm supposed to be an expert. I should have opinions. I should have biases. If we're going to do guidelines, you need people with the opposite opinions and biases also to be in the room to argue against mine. Okay, we've also got new innovations. People may have heard of 3-MDR. In Cardiff, there's a study that's just gone to press. And it's showing good effects for some patients, but crucially not all. There's a dropout. Some people can't do it. So what about the guidelines for PTSD? Okay, it's not supposed to be a choice. It's not binary. Okay, it should be both guidelines and choice. Okay, the study by Hamblin looked at 5 major guidelines, and they did not agree with each other. They didn't agree on methodology. And we've also got the Matrix in Scotland that wasn't mentioned as one of those, and it's slightly different because of the context of NHS and implications. Okay, the guidelines only measure generalities, so prazosin doesn't come out as effective because it only affects 3 symptoms in PTSD, so it can't reach the cutoff for effectiveness. The absence of evidence is not evidence of absence. It does not mean because there is no study that the therapy doesn't work, and NICE shouldn't be used like that, and it often is. Has anybody read the NICE guidance on PTSD? Yeah. Well done. So that's a 54-page document. It takes a little bit of reading. Does anybody know that there's a 317-page document and a 1,300-page document? Okay, all the good stuff is hidden in the big one. Okay, they have strong recommendations for NICE, but low-quality evidence. They say that EMDR should only be used in non-combat veterans. The issue here is I don't think they understand the trauma that happens in combat veterans. Sorry, I said non-combat, it's combat veterans. So you should only use it non-combat related PTSD. Okay. Oops. Okay, so page 280 of the 1326 document. All evidence reviewed was of low or very low quality, i.e. one extra study would change the guidance, which is remarkable. And that study would not even need to diagnose PTSD, just use questionnaires. Doesn't even need to be big. Page 281, they agreed to make strong recommendations despite the uncertainty, which is remarkable. And yet we're tied to those recommendations. Okay? Just to say that they're very open, they say who's on it, they also have conflict of interests, and the majority of people have leanings towards CBT and one or two with EMDR. Okay? They're experts, they should have opinions, as I said, but you need to balance that. Okay? The role is to guide us with treatment, but take that alongside the patient preference, the values, and the clinician's experience and their judgment. They're not mandates, they support decision making. The Institute of Medicine said that you shouldn't base this on a consensus, and yet NICE says that over and over and over again, when there isn't evidence, because they've rejected a lot of evidence that doesn't meet the criteria that would guide them. Okay? I'm kicking yet another hornet's nest. Why, if you're going to say CBT, do you say you've got to follow a manual? Does that not neutralize the effect of the clinician? You make them a research assistant. I don't think that's appropriate. A clinician could have 25 years experience. Okay. I'm going to go forward a little bit. We're talking about guidelines for PTSD. There are 636,120 different ways to get a diagnosis for one disorder. Two people can have the same disorder and not have a single symptom overlapping. Do we trust the diagnosis? Have we got that right? And for the studies in the guidelines, only the ISTSS said you had to have a diagnostic interview. Okay? So what do you do with patients who are beyond the guidelines, and many, many patients are? Okay? You can see the child and the tiger have seen this play. That part of the mesolimbic dopamine system is activated. Okay? Comorbidity should not be ignored, but it takes you beyond the guidelines for the most part. Okay? I'm probably running just about there. Yeah. I'm not going to get to all of the treatment, I'm afraid. I've got so involved in the neurobiology, apologies for that. Too busy kicking the hornet's nest. If you're treating complex reaction, your experience will not be that CBT and EMDR without lots of resourcing is actually going to get you to where you want to be, either for the patient or for the therapist. Neurobiology does challenge talking therapies in a very, very big way. And that lack of trust that a patient may have will not be embraced easily within this method. Okay? The other big thing is that therapists avoid using imaginal exposure. They won't use it, they're terrified of it. I trained people for 14 years in it and they really didn't want to use it. Okay? Most striking discrepancy between recommended practice and actual practice. Okay, so the guidelines are saying this is what we use, and clinicians are saying we really, really don't want to. Okay, we need to do something with that, not just keep embracing what nobody is doing. Okay? So we've got studies that show pre and post that we can change the brain. And therapists really do keep going for more and more training because what they're trained in is not working for the patients they see. Yeah? Does that make sense? I've asked them. I go to these trainings. A group of us go to all of them. Yeah? Complex PTSD phase treatment. That is now accepted. It's in the guidelines. So you do stabilize and safety, then you do trauma treatment, and then you do the reintegration. Well, the evidence is actually not that strong. We've embraced it. When you actually look at this, it's not supported, but yet it's what we're supposed to do. I sit on the other side of that. I think you have to resource people, and resources and resilience are actually domain-based. You can't increase resilience in one domain and then treat them with that domain not being appropriate. If it's about interpersonal trauma, you've got to resilience them for interpersonal trauma, okay, in the interpersonal domain. So, yes, I'm on the other side of that, but we need to hear the argument. And I'm just going to go forward. Can I just do this one last slide? Give me that, just this one. Thank you. I want to just talk to this. I'm sure there's a number of therapists in the room. Okay? The unhealed therapist. And actually we've become in this country quite proud of the fact that we don't do personal therapy. But that means we bring our trauma into the room. We bring the stuff that has maybe led us to become therapists to help others, but we bring it into the room, and if we get triggered, is that safe for the client, the patient, to be with us? Will they allow treatment or disclosure if we're so triggered that we don't feel safe, they don't feel that there's any opportunity for that engagement? Okay. And again, hobby horse takes two to tango. We've got to be available, and they've got to feel safe with us. Okay, and I'll stop there. Thank you. Sorry for running over.